So somebody wanted to know about bilateral fourth nerve palsy and how we can differentiate this from the unilateral palsy, as well as the clinical features that suggest it's bilateral. So as you know, if you have a unilateral palsy, for example, a right fourth, you get a right hypertropia, and on the three-step test, it's going to be worse on left gaze and right tilt. So it's kind of like a marching palsy, right, left, right. And if you have left, you get the reverse, a left hypertropia, worse in right gaze and left tilt. So if you have a bilateral palsy, it's kind of like a combination of a right and a left. But in primary position, the right hypertropia and the left hypertropia kind of cancel out. And so you might have no hypertropia in the primary position. And then you got a reversing hypertropia, a right hypertropia in left gaze and a left hypertropia in right gaze, which is a reversing hypertropia. And the same thing with the head tilt, a right hypertropia in right tilt and a left hypertropia in left tilt when you do the third step of the three-step test. So when we have this reversing hypertropia, either with the gaze or with the head tilt, then we know that that can't be a unilateral fourth, because a unilateral fourth can only cause an ipsilateral hypertropia. It cannot suddenly reverse and go from right side to the left side. That's a bilateral. And the tricky part is there might not be any primary position deviation because two hypertropic eyes cancel each other out. The other thing that we want to do is the double Maddox rod test. That's to look for torsion. And so if we have greater than 8 degrees of excyclotorsion, that's usually a tip-off that we might have a bilateral fourth, because you really shouldn't get more than single digits out of a single fourth nerve palsy in terms of the torsion. In addition, when we're doing the deductions and the versions, so here's the H diagram, we'll have bilateral underaction -2 or -1 or whatever of the ipsilateral superior oblique, and there'll be an overaction of the inferior oblique muscle, and that will cause the eye to have a V pattern on the gaze up, because you get this overaction of abduction from the inferior obliques, so it makes a V pattern exotropia in up gaze. So we should be thinking about bilateral fourths, especially in trauma cases, because the fourth crosses in the dorsally exiting posterior medullary, anterior medullary velum. You've got a reversing hypertropia, so it's a combination of right and left hypertropias. In primary, there might be no deviation. You get a right hyper in left gaze and a left hyper in right gaze, and a reversing hypertropia on the tilt test. We're going to be looking for double Maddox rod greater than 8 to 10 degrees of excyclotorsion, and bilateral overaction of the inferior obliques producing a V pattern exotropia in up gaze.